Alastair Younger is going to be taking us through one of the exciting parts of foot and ankle over the last few years, MIS surgery for the foot and ankle. Our sponsor for this session is Stryker, so we thank them for making this possible. Alastair, it's all yours.
Hello, everybody. Can you hear me? And so I'm just going to go back one slide, if I can, and introduce our faculty here. Our faculty is Pete Mangone, who's a friend and colleague from Asheville in North Carolina, Beccy Cerrato from Baltimore, and Kevin Wing and Andy Veljkovic, who are both with me in Vancouver. So this is going to be a case-based discussion. We've got cases submitted from Dr. Wing and Dr. Cerrato, and hopefully we can get through a fair amount of this. So moving on, the benefits of MIS. We've all seen this, the wound breakdown, and it's the bugbear of foot and ankle surgery. And so simplistically, if we minimize the wound, we will minimize the complications. So the challenges of MIS surgery, while we minimize wounds, is to achieve the same anatomic result as open surgery, and also avoid the wound complications. So in this session, what we're going to do through cases is discuss the percutaneous hallux valgus, percutaneous fusions, percutaneous osteotomies, and percutaneous debridement, not in that specific order. The tools that you need to learn how to use is the arthroscope, but also specific tools, a low-speed, high-torque burr, the mini C-arm, and palpation will be your guidance. So moving on here, Kevin, this is one of your cases. So do you want to just give us a quick history on this patient?
Yeah, comes into the clinic complaining of her obvious painful big toe, but also when you ask her a bit more, significant medial sided ankle pain. And so when you carefully examine her on her physical exam, you do note that her heel's in a little bit of an increased valgus. She's got a bit of a midfoot break, a hint of too many toes, and then the obvious markedly unstable first ray. But the big toe is reducible and tracks reasonably well in the reduced position. In the seated position, she's quite tender over her tib post.
Beccy, how would you manage this using your percutaneous tool options?
My bunion procedures per choice, I typically look at a couple of things. So the MIS, Chevron, and Aitkin, I do for my mild and moderate deformities. My more severe deformities or patients with hypermobility, I look at the lapidus. And then for either severe deformities and or hallux rigidus and other things, I may even consider the fusion of the hallux MTP joint. So since this patient falls in that hypermobility in combination with a symptomatic flat foot, this would be a lapidus.
Okay. Hindfoot procedure, what would be your choice there? If you decided to correct the hindfoot too, what would you go for there?
With a stage 2 flexible flat foot healthy subtalar joint, I'd be doing a heel slide, gastrocnemius recession, depending upon the health of the posterior tib tendon, either a transfer and or augmentation, spring ligament, and then I would be doing a lapidus on this patient, not just to address the bunion that she clearly has, but also just to stabilize that medial column.
Pete, anything else to add?
Yeah, so I think a calcaneal osteotomy, is something that definitely works well in this case to move that hind foot into a more neutral position. And I think the benefit of doing it with an MIS approach here is oftentimes in these cases, I will even I've gone to adding a peroneus brevis to longus transfer to, try to get some more plantar flexion strength to the first ray. especially if I don't do a lapidus. In this case, if you're doing a lapidus, that may solve some of that problem, but at the same time, there may still be a little bit of navicular cuneiform instability, and getting a little bit more power to the peroneus longus can help. And so by being able to do a percutaneous, minimally invasive calcaneal osteotomy, you can safely make that peroneal tendon incision much more confidently than when you have to make dual incisions, or you try to make one large exposure for that calcaneal osteotomy, which can be difficult.
So Kevin, do you want to take us through what you did here and your technique for your medializing calc osteotomy?
Yeah, sure. And just as a note on that plan, I agree with Rebecca. I actually had a gastroc slide on consent and did it in the case because she was actually quite tight, and certainly in the setting of a stage 2 flat foot, I don't hesitate to do the gastroc slide. Yeah, I've been happy with the MIS technique for the reasons that Pete described. You know, once you get some hands-on in the cadaver very quickly, in keeping with what doctors like Joel Vernois taught me, you know, if you get that true lateral, position yourself with the foot off the end of the bed, then it's easy to figure out your start point, and it's easy to use the forecut technique to give yourself a little bit of a chevron osteotomy. And then because with the, you know, 3 mil burr and with a little bit of what happens as you cut, you know, you probably are taking out close to 4 mils, which gives you the advantage of fairly easily being able to dial in the amount of shift that you want. And, you know, you can fire a wire up, you can take an intraoperative calcaxial, you can palpate it, you can look at it, and you get both shift and if you want a little bit of rotation, you can have that too. And so that's what I've done here, right? And I purposely started the first screw that I put in a little bit laterally in the calcaneus to keep both the translation and the rotation that I achieved with the elevator. So I've been happy with the technique.
Andy, you have some variations on this, and you know, you've got a percutaneous technique for the gastroc, and also you do your calcaneal osteotomies a little bit differently. So do you want to just take us through how you'd address the hindfoot here?
Yeah, no, I think Kevin did a great job. I just do an endoscopic assisted gastroc recession with 2 portals, which I've been doing for quite some time, and it's just nice. You can actually dial in the correction. So depending on the amount of equinus, you can gently go across the calf to the point where you can actually dial in. I usually try to leave in about 10 degrees of equinus, but I'll go all the way across to the scope and then dial that in. For the calcaneal osteotomy, I've been using a scope assisted or endoscopic assisted calcaneal osteotomy, which is using a scope cutter to transfer jiggly wire across the calcaneus. I like it because I can actually, just by the way you kind of move your hands, you can either make it a dome, you can make it straight, and it's a straight oblique. And so then you can actually shift the calcaneus up, down, side, medial, lateral. So I like, and you don't get a lot of shortening of the calcaneus, which is nice. So I like that part, specifically in the plane of valgus foot, so I don't diminish the calcaneal pitch. But I mean, to me, I think every technique works well. It's nice not to open it if you don't need to open it. So that's how I would do that.
And lapidus or cotton for this?
For me, it should be a lapidus for this case, and I would consider doing a peroneus brevis longus in addition, just to give it a little bit more strength in the midfoot. And I'm assuming there's not a lot of pain in the tip post at this point. I'm hoping.
Okay. So excuse me, sorry. And so Kevin, here's your result. So you've got a nice correction of the talus to first metatarsal angle, and a nice correction through your lapidus there. Any other comments from the rest of the panel? Okay, we will move on. Here's your AP view. Nice coverage of your tailor head as well, which is great. So you can see that the tailor head is now nicely covered with your transfer here, and you got your soft tissue procedure as well outlined. The FDL transfer involved as well. And your hindfoot correction here. So any wound healing problems you've had with your Parekh techniques, Kevin?
No, not that I can think of. And as you pointed out, Alastair, I think that, using the tool, and as you get more experience with it, you get comfortable with just the amount of pressure and the amount of speed, and the idea that, if you keep it very gentle, and you're trying to keep the cutting teeth in the bone, hopefully, the either issues with just the amount of scarring you're getting in the skin, or heat transfer to any sensory nerves that are nearby is really minimized, and so been happy with the technique.
So you go try and make sure you go pretty low speed with the burr.
Yeah, absolutely right. That get it cutting, get it inside the bone, and then it's just no faster than you need to with the variable speed foot pedal, and then just the right amount of pressure to keep cutting, but without heating things up, and I've been happy with that technique.
So for the panel, who's tourniquet up and who's tourniquet down with the burr?
I don't use a tourniquet.
Pete?
Same, I don't use a tourniquet for my minimally invasive procedures. I did want to make one point about soft tissues, and I agree with Kevin, it comes with experience, but one of the things that I've tried to do with these smaller incisions, whenever I'm doing either an exostectomy or an osteotomy on a large bone like this, is once I get the osteotomy fixed, is I'll irrigate those soft tissues through that small incision very aggressively with a syringe and a catheter tip, because sometimes that bony debris, if you leave a little bit of bony debris in the soft tissues underneath the incision, that'll just, the body just reacts to that with a little bit of foreign body reaction. Sometimes I've seen in patients will get a little bit of irritation. So I really try to focus on irrigating those soft tissues before I close.
So for the panel, what was your first procedure that you did in a patient once you learned how to do this technique? Kevin, what did you start with?
Yeah, I started with the calc. As Peter pointed out, you see some complex cases where doing the calc MIS really makes you feel happy. And then it just turns out that the way I learned it in the lab and my confidence going in the OR was high. And as Pete said, start this part of the case, no tourniquet, use the tourniquet later on in the case when I'm doing some other parts of the procedure.
Pete,
I would probably not recommend how I started with the bunion. But I sort of, as you guys know, I had been practicing and training and teaching on MIS probably a couple of years before. A lot of that stuff was available stateside for us. So, when I first had it in my hands, I felt comfortable enough to be able to do a more complicated procedure such as a bunion. I don't know if that's necessarily what everybody should start with.
And Andy, how did you start with your Perk osteotomies? You obviously have a slightly different technique with endoscopic assisted, so I assume you're doing that with the tourniquet app.
I do the tourniquet app, and I've been doing it like that for the last 12 years. And it's been a really nice technique. So I've done the burr technique too. It works really well. So for me, neither here nor there. I found that the bunion part was much harder though, doing it with the burr. So yeah, I'm going to agree with Beccy. If I was to start, I would have started with the calcaneus.
Okay. So next case again, one of yours, Kevin, here. So going the other way around. So this is a patient with a cavus foot. So do you want to just take us briefly through the history on this patient?
Yeah, 49, now an office worker, avid basketball player when he was younger. Can't keep track of how many times he sprained his ankle in his playing days, and slowly stopped playing and just having trouble with the foot turning over on a pebble on the sidewalk. He's able to tell you that he's noticed that his arch height's increased as his foot changed on him over the last 3-4 years, and really having problems with pain around the lateral ankle, fibula, base of fifth plantarly, and he stands in front of you with clear asymmetry. His one side might be a little bit of, a higher arched foot shape, but his heel still sits in a valgus. This side, the heel's no longer in any valgus, sitting in a few degrees of true varus. He's tender over his perineals. In physical exam, you can't really demonstrate that either perineal seems to fire.
Okay.
Yeah.
So for the rest of the panel, no perineals, what would you use? Beccy.
Typically for patients, this cavovarus, if they have no perineal strength, so a CMT patient, I usually do a longus to brevis, but if it's outside of that, let's say a spine patient, and they have, common perineal nerve weakness or whatever, I'll do a FHL transfer for those patients. And that's usually the two options that I do for my perineal tendons.
Have you harvested the FHL percutaneously? Like some of our European colleagues have discussed, and also Hong Kong, Derek Louis talked about as well.
Yeah, I mean, I think my incision on the medial side might be a little bit bigger, but my incision on the medial part to obtain, to release the FHL is 1.5 centimeters. It's really small. And so it's a tiny incision to be able to identify, release it, and then through that lateral incision, it's very easy to obtain. So I would argue it's pretty minimally invasive. Maybe not as minimally invasive as Dr. Liu.
Pete, any FHL tips and tricks here? What would you do?
Well, I mean, I think the FHL is an option, and I certainly have used that, but I really try not to use that if I can in patients. And I've found, especially in this patient where you really don't need the perineus longus, I usually will use a cadaver allograft. And in most cases, I can get enough perineus brevis. There is enough perineus brevis available that I can at least get an end-to-end kind of anastomosis on one side, and then I tie it directly into the fifth metatarsal base with an anchor, and I can get that functional perineus brevis kind of activity going. Free up the adhesions, and then the perineus longus I just let fly, or if I can get some attachment, I'll transfer it to the perineus brevis to add to the lateral power. And then again, this is where a minimally invasive calcaneal osteotomy through a small incision really plays a role, because you don't have to make these dual incisions that have a very thin skin bridge, because you're going to have to do an extensile perineal tendon, kind of a lot of work in that perineal tendon space. And not trying to disturb the soft tissues posterior to that can be very helpful. And then in some of these patients as well, I've found if I don't have to do a tendon transfer down to the base, if I'm able to fix that. Some of these patients also have base fifth metatarsal kind of callus. And even with a lateral slide of the calcaneus, they still have that prominence. And I've been able to do an exostectomy, minimally invasive, on some of these patients where, again, you're doing maybe a perineal tendon procedure up more proximal, and then you can make a small incision to take off a little bit of that post or plantar lateral fifth metatarsal base, where some of these patients have a fairly big callus and will complain of that sometimes as their even primary complaint when they come into the office.
Any arthroblastum in this, or would that be expecting too much? I mean, I guess you got to make a lateral incision anyway. Any role?
Right. Typically, for a large exposure like this, I just do it open, but I am able to do it kind of with a mini brostrum, mini open brostrum technique, where instead of doing an extensile exposure, I can kind of just get enough exposed to place the anchors, and then pass those sutures in a semi-percutaneous manner, so I don't have to lift up a large lateral flap. But arthroscopically, probably not in this particular case, because it's such an extensile lateral approach for the perineal tendons.
Any experience from everyone with the percutaneous hamstring reconstruction as advocated by Mark Glazebrook and Matt Takao?
I think in the big deformities, I think it's sometimes important to open it, because often you'll find that lateral talar process may block you to get your flexion. So I find that you can do that with a scope and actually burr it down with a scope. But I find that when you have that large extended lateral talar process that's blocking your ankle from rotating back in the large deformities, often it's easier just to do that and have a saw there, and then actually do the open ligament reconstruction. And sometimes you need allograft too if it's in really bad shape. So That's one of the things, depending on the actual deformity and how bad the deformity is.
Okay, so let's go, and your technique here is from the medial side, Kevin. So you want to just take us through that, and whether or not you release the flexor retinaculum as well.
Yeah, you know, whether it's that shortening, but you know, no, I haven't been releasing the tarsal tunnel, and that was based on a recommendation from Joel Vernois, who's done lots as well, and so I haven't seen that particular complication as to being a concern. And you know, when you talk about nerves at risk, well, on both sides of the calcaneus, you've got sensory branches for sure in play, and then ideally you want to be staying well away from a true, you know, motor part of tib post. But I think when you're using the typical chevron starting point, you are quite clear of everything but just the sensory branches on both sides. So this technique, like we talked about, goes slow and allows you ergonomically to do your lateralizing shift just through the small medial sided approach. The setup here with the beanbag and the true lateral, it gives you a lot of confidence that you can do the first MIS part correctly with the help of your OR staff, a little shuffle around and jam the beanbag under his hip and put him more in the sunny side up position with a bolster. So you've got a nice look at the perineal tendons that you're going to see later. And, you know, that's the part for this. You know, not only is the physical exam in this guy impressive, but his CT doesn't show ankle arthritis. His MRI shows severe tendinopathy over the whole length of both tendons. And so, you know, I was prepared for what I found here in the slides to come.
So the rest of the panel, anyone else have experience from the medial side for the calc osteotomy?
I do not.
I don't.
I
This
don't.
is great.
Okay. Are you flexor retinacular releasers? Anybody else?
I have not released the flexor retinaculum, and like Kevin, fortunately I've not experienced any tarsal tunnel issues in my patients where I've done lateralizing calcaneal osteotomies.
I do any larger deformities, so like quite large deformities where there's a massive slide, I do the tarsal tunnel releases.
Yeah, same here.
Yeah, this is, I think definitely with the CMT patients with big fat nerves, you worry about that. And we wrote a paper on that a while back on CMT patients getting tibial nerve palsies from lateralizing calcaneal osteotomies. Those also I would tend to harvest the perineus, tibial posterior and swing it around to the lateral side. So it's another potential tendon transfer. So Kevin, you've got your screw fixation going in here and your correction. How do you judge when you've gone far enough?
You know, you're taking fluoro as much as you want doing this. And so you can see with this medial approach, you know, I'm nowhere near the motor part of tib post. The sensory branch can be in play just like the sural on the other side. And so you're trying to use good MIS technique and slow speeds and stuff like that. Otherwise, that elevator in there, making sure that you've completed all 4 cuts, it's nice and mobile. You can get it to translate. And you can, you know, on your fluoro shot, judge your angle with your elevator. And so the wire goes up and you're good. And of course, the other trick, as many of you probably know with any of these calcaneal osteotomies, is you don't have your assistant holding it at 90 while you're trying to translate it. But once you have it in a good position, then you can retighten the plantar fascia and the Achilles and seat the calcaneus where you want it to give you additional stability as you get your wire and screw placed.
So there's your technique here. So 4 cuts as well as you would do on the other side. Anything else to mention working from this medial approach?
No, just like we talked about. I mean, no tourniquet. I'm running irrigation. I use a mosquito to open the skin after my little skin incision and get the cutting teeth into the bone. And then it's that real feel of just keeping the edge of the cutting teeth on the cortex as you work your way around. So you don't have very much of the burr outside of the bone. You're going slow. You're running irrigation. You don't have the tourniquet up. And For those people who are familiar with this technique, the only real learning curve is that when you first do it, it's easy to, momentarily lose your feel and leave a little bridge of bone somewhere. And so you spend a few minutes hunting around to figure out where your little bridge of bone is. Once you're completely free, it's quite obvious that you've completed your osteotomy and the tuberosity is mobile.
And here's your screw fixation. Andy, how do you know when you've gone far enough? You do a lot of stuff, Andy, with long leg X-rays and stuff. So how do you judge it on the table when you've gone far enough?
So I judge it visually, but I also use a large C-arm. I do use small C-arm in the problem, just measure in advance by using the mini-C. But I use a large C and I use the axis of the tibial axis and just aim for the second ray. Generally, but I also template preoperatively and also look visually. And so you can get a nice correction with these osteotomies. You can rotate it, you can slide it, so you have an option to do both things with these MIS type osteotomies.
And here's your tendon transfer, Kevin. So this is sort of a hybrid procedure with a medial FHL transfer. So we've talked about that. Non-weight bearing for 6 weeks. Does everyone keep calc osteotomies non-weight bearing for 6 weeks? Or anyone get them going sooner?
I've started most of my calc osteotomies now, especially with my minimally invasive protocols where you're not stripping a lot of soft tissues. I'll have them, I keep them off for 2 weeks, essentially just to let the soft tissues from the entire procedure kind of cool down. And then I let them start to progress. Usually I'll let them do 50% and kind of progress from there if they feel comfortable. And I've not had an issue with these osteotomies moving or shifting. But I do use 2 screws to hold them, not 1.
Right. I think we've Kevin, this is a wound issue you're showing here. What's the story behind this?
As you know, it's just as Pete alluded to earlier. If you're going to do the calcaneal osteotomy and you've got an extensive perineal problem, it's difficult. You either leave a skin bridge or you kind of have a big incision that you're trying to work both ways, and the skin edge gets retracted, it gets beat up by the saw, and so this is just a case that for me kind of sealed the advantage to in the MIS technique, and so I think that this lateralizing case really shows nicely the advantage of just this different technique to do the calcaneal osteotomy that most of us think is helpful and important in this case, but also in a setting where in my hands, I felt more comfortable that, he was so scarred down, but he still had viable muscle proximally in his perineals. I wanted to get all the way proximal, chased down distally like Pete said, but at the end, really, there was just a tiniest nub at the base of the fifth left. And that's where I knew I wanted to go long FHL as opposed to allograft. But the FHL came around, went to the fifth, but then the residual longus and brevis went into the base of FHL. And I don't know if you're going to show us the video or not, Alastair, but I mean, pretty impressive function the guy got, 3 months afterwards.
Yeah, sorry, I don't have the video there, and I'm going to move on to Beccy's cases. Oh, sorry, no, this is actually, excuse me, I just got one of my own here, which I did I actually did an OCD and a lateral ligament, and he had ongoing perineal tendon pain. So I did a Parekh lateralizing calc osteotomy. I don't think there's much to add to the technique, except for the fact that I used headless screws. I do find these, the screw site does irritate. So that was probably my only variation on the technique here, and follow up. So moving on.
Alastair, just
Yes.
real quick on the calc osteotomies, I know that is a place where a lot of people start, and I think Kevin talks about kind of having good technique. I do think it's important that when people know that when they start, that it will probably take you longer initially to do these osteotomies if you do it correctly until you get a feel for the tool. And so it's just important that people have patience as they start into the process, so that they learn how to use the tool properly, you use proper technique, and then as you get better at it, you'll get faster, like anything that you do. But it is important to have patience and use the C-arm a lot in the early going with this and or any minimally invasive procedure.
And cadaver courses too. I think we mentioned that. So Becky, here's your first case, patient with bunion. Do you want to just quickly take us through the story here?
Sure. So this is probably I see about 10 of these a day in my clinic. So this is a 43-year-old woman who's had a long, almost a lifelong history of a bunion. On her, in her case, it's a right side only, over 20 years. But the past 5 years is where she'll describe increasing pain, difficulty with activities. She's healthy. When we look at her exam from a hindfoot, ankle, and foot alignment perspective, she's got neutral alignment. This isn't a flat foot deformity. She's got a right hallux valgus deformity with no lesser toe deformities. She's got a stable first TMT joint. Her hallux MTP joint, and I think this is important when you're looking at bunions, MIS or not, is to sort of understand the health of the big toe joint. So she's got really good painless range of motion. She's got a passively correctable hallux MTP joint out of that valgus position. And then when you palpate her, she really doesn't have any pain at her sesamoids, and she has a negative grind.
So Becky, I have to apologize. I did try and put your logo on here from Mercy, and I was unsuccessful. I guess it's one of the Zoom risks, as apart from having an IT group at the back of the room. So just yeah, X-rays here. Yes.
Yeah. So these are X-rays for this patient. She's got, a wider IMA, a moderate hallux valgus deformity on her hallux valgus angle. The joint looks relatively healthy. You can see her sesamoids uncovered. And I think for me, and my suggestion for patients or for surgeons that are starting to do MIS bunions, particularly the MICA, I think doing very small deformity cases, that's not where you want to start. So this might be an ideal case to start doing the minimally invasive chevron on. I find it to be technically easier to be doing these shifts and these corrections in these patients that have wider IMAs. I'm sure the panel would agree. When I first started doing this, as Alastair had asked, the first MIS case I did was a bunion, and I cherry-picked this I was more interested in avoiding trying to do the medial eminence resection, and so I cherry-picked this patient who had no hypertrophy to the medial eminence. She also barely had a bunion, and that is technically can be a much more challenging procedure to do. So I think for and the panel can talk about it, but for the surgeon that's looking for their first MIS case, I think this would be, one that I think you should feel comfortable doing in the beginning.
Why is it technically hard to do a minor deformity with your your MICA?
I think because with these cases, so what we're doing is you're placing the apex of your chevron osteotomy extracapsular, and you're looking to shift this over, and she already has that wider IMA angle, and so it can be a very nice correction as you're shifting it over. It just, again, to not have to learn how to translate it over, struggle with that tight, soft tissue, the periosteum on the lateral side, all of those other different things. This tends to be the easiest case to do that on in the beginning.
So rest of the panel, Pete, what would you do with this?
So definitely. So when I look at this patient, I look and she has a no gapping on the lateral weight bearing view, almost has a little bit of a cavus foot. And even though a wide IM angle, and because of that, I try not to stiffen the medial column any further. So I would do a MICA or MICA type procedure in this, definitely. And for the reasons Becky outlined, it is actually a little bit easier. And part of that is because you're shooting your K wires from the proximal first metatarsal more obliquely, whereas when the IM angle is less, your K wires at a more tangential direction, and it actually makes it a little bit more difficult. Whereas, it's more oblique otherwise. I think the big key though is when you do this is you have to be aggressive and shift that head, 80 to 90%. Shifting it 50% is not going to work in this case. You really have to be comfortable shifting the head, understanding that it will heal. You fix it with the correct technique, it will heal. and be comfortable with that shift. That's the only part that's difficult on the early phases, is being comfortable going ahead and shifting it over and knowing that you're going to shift it over far enough. And once you do that, shooting the wires and the screws for this are easier than a less acute angle that you're dealing with. But for me, this is a patient who's ideal for a mica procedure as opposed to a first TMT fusion, because they have somewhat of a cavus foot to begin with.
Andy and Kevin, what would your choices here?
I mean, for me, I would consider doing something like a scarf for this type of procedure. I'm not sure, Kevin, if you'd be doing lapidus for this.
Yeah, I keep it simple. I'd still be doing a lapidus, but I think Pete makes many good points. And I think that when you've got that technical expertise like Pete has, and you see enough of these, then I agree. I've got no qualms with the fact that in a skilled surgeon's hand it'll do very well. And some patients are really going to appreciate the mica aspect of it.
And here we go. So it's just a close up there, Becky, of your MTP joint. And so do you want to just take us quickly through your technique here?
Yeah, so where I place my my burr is going to be kind of a millimeter or so proximal to that medial eminence, as you can see there. If you look at the techniques, the burr is most burrs are about 2 millimeters. So you're going to lose some length to your first metatarsal when you do this, and you have to compensate for that. And so if I don't want to do anything to the length of the metatarsal, you want to angle that burr distally about 20 degrees, and then you're basically going to compensate for the width of the burr. But obviously, if it's a stiff, more arthritic patient that may have a greater length in the first metatarsal, I may want to shorten it. And so maybe I'll make it, perpendicular to the second metatarsal, or in some situations, I may actually angle it more to lengthen. So again, some of the, recent literature has, argued that minimally invasive bunions, particularly the mica type technique, it's, inevitable to shorten it, but that's not true. I mean, as the surgeon, when you place this burr, you're going to dictate where this head is going. So you can see that sort of translation with this. And on this view, I think if you advance a couple of the slides, you'll see, I think I highlight some of that. This shows you that short little chevron. And so on the AP view, you can see that little sort of almost tail on the plantar aspect that you can see on the AP, and then translating it over to the lateral side, you can see that as well. As Pete had mentioned, even in the, mild or even severe cases, even if you don't plan to translate this over aggressively for a correction, I think in order to be able to get this more proximal screw to exit out of the lateral cortex on that first metatarsal, a good 10 to 12 millimeters before your osteotomy, it almost forces you to translate the head over probably no less than 70 to 75% anyway. And so that was probably a learning curve for me, is to get comfortable with the idea of that, irrespective of some of the deformity, just how aggressive of a translation you're doing over. And then the other thing I think I highlight on this, I think a little bit later, is, being able to, I try to make these screws as proximal as I can and more longitudinal within the metatarsal to the head, as opposed to introducing them more distally. Number one, so that I can make sure I get that good bone bridge on that first screw, that lateral cortex bone bridge. But also, I want to be able to go in there with my burr when I've finished the translation and the screw fixation. I want to make sure that I'm able to then resect that spike that gets created when you're shifting the head over. You're also translating, you're shifting that proximal fragment more medial. And so it's almost as if you've transferred your medial eminence deformities more proximally to that medial spike. So I want to make sure that I'm able to, shave down a large segment of that. And I think the more proximal you start your screws, then you're able to do that.
Okay. And here's your, I guess your follow-up X-ray too, and you've also resected the medial side here.
Mhm.
Always an Aitkin?
I would say probably not always, but it's probably 80% of my cases I'll do Aitkins.
Yeah, Pete?
I agree. I use it about 80% of the time.
Kevin, are you an Aitkinator with your lapidus?
No, I'm mostly a non-Aitkin.
And Andy, are you Aitkin too with your
I
scarf?
ache a lot when I do a scarf type or distal osteotomy like this.
Okay, and I think so that was the medial eminence resection. This
I
is
think this is highlighting another case of a patient, a little more mild deformity, but I think I was able to show, if you go to a couple of the other slides, here's a patient at 6 months. And so you can see 6 weeks and you can see 6 months. And those of us who see some of this, again, she didn't have a severe deformity, but it doesn't matter when you're translating these over and you're relying on that most proximal screw to get that good lateral cortex, you're going to be shifting them over no less than 70 to 80%, let alone 100%. And so you can see that in this one, and you can also see all of that remodeling that happens. Typically, this is what we see when we see patients back at about 6 months.
Hey, Becky, I have a quick question for you with this case. This is something I've seen with one of my cases. If you look at that 6-month follow-up, there's some minor widening in the first TMT area. What's your thoughts on that? I've had that happen on one of my patients, and I didn't know what to think about it. And the patient's super happy. They're super happy with their correction, but I noticed that there's some minor widening in that Linz-Frank interval. Any thoughts on that at all?
Yeah, no, I agree with you. I've noticed that as well. And not everybody develops it, but I think if you look back at the X-rays, it's not just even at 6 months. Typically, once they're about the 6-week X-rays, many of those patients, you'll see that. And I think it's just, again, with this translation of the metatarsal head and that medial force it puts on that proximal fragment, you'll see it. I follow all my bunions, scarfs, micas, whatever it is, lapiduses, for at least 1 year. And those that I've seen this lateral translation at the first TMT joint, I see it early, like you noticed, but I have not seen it progress, at least until that, out to the first year. I can't comment on what they're going to look like, 5 years out and stuff like that at this point.
I haven't seen it progress either. That's why, but I did notice it in my patients, like and a few of them when it was probably about the 6-month mark. And I was confused as sort of why it's happening, but I didn't see it get worse. And the patient again are running and having a great time and not complaining of it. So it's interesting.
Andy, I think it's so I subscribe to the philosophy that I try to pull that first ray out as far as I possibly can. And as David Redfern talks about, pull the slack out of the first TMT. So oftentimes my immediate post-op X-rays at 4 to 6 weeks are open in that location. And that's what I think when I got much better at this is when I really thought about the translation as not just a translation of the metatarsal head laterally, but a pull of the first ray medial and really pulling the slack out of, so you're basically taking all the laxity out of the first ray proximal and shifting that head over 80 to 90% or sometimes 100%. And once I've done that, I have not had any recurrences because they kind of are at their maximum tension at that point in time, and you're recreating the true windlass mechanism of that first ray.
So this another case here of yours, Becky. So bilateral bunions. We'll get to the pictures here. So what's your thoughts on this case?
Well, so this, I wanted to have a conversation with the panel. So this is a 65-year-old patient. Do any of you guys doing MIS, particularly the Mika type technique with the 2-screw fixation, do you guys have any cutoff or age cutoff or concern for bone density or bone health when you're doing this type of procedure?
Kevin, what's your thoughts on the older patient with, would you go to MTP fusion or would have other sort of tips or tricks about the osteoporosis risk?
There's no two ways about it, Alastair, that the longer I've been in practice, the more MTP fusions I do. I don't hesitate to offer that for some patients if I think that, you know, I've got other factors conspiring against me. Yeah, leave it at that.
Hey guys, I've got two questions that have come through. The first metatarsal shortening that you may get with the Mica, do you guys find that it causes metatarsalgia? And if so, how are you guys managing that?
Pete, do you want to address that?
Yeah, so first of all, I've not seen first metatarsal shortening. So I think that, as Beccy pointed out, it has to do with how are you doing your osteotomy. If your osteotomy is angled either, you know, in a negative direction, kind of more proximal on your first ray, then you will shorten. But as long as you do your osteotomy in the correct direction, you can translate as you translate the head distally, you actually create and make up the length loss from the burr. So I've not seen that to be an issue, and you know, I've had basically no transfer metatarsalgia issues in my cases. But I think it's a technical thing, like any bunion procedure. You can overshorten if you do your osteotomy improperly or fix it in an incorrect location.
Quick question for the whole panel: would anyone consider, if you had, you know, an obviously long second ray and hallux valgus deformity with second metatarsalgia, would you do your Mica and then add a shortening osteotomy of the second ray, or would you go never do that, or would you do second, third, and fourth metatarsal shortening osteotomies? Beccy, what's your thoughts on that?
So as Pete alluded, if I have a patient who has transfer pain prior to doing any kind of bunion correction and the second is longer, but the second has no deformities. So it's not a crossover deformity. It's not elevated. There's not an incompetent plantar plate. I will do my bunion correction surgery with the goal of, number one, not shortening, and number two, when you're translating it over, you can direct, again, the apex of this correction as you translate the head lateral, you can also plantar translate. So it's a better weight bearer. And so if in the absence of a deformity and simply pain, unless it's some crazy long second, I will rely on my correction of the bunion to help with that pain. And I talk to them about that. In the case of a patient who has a long second pain, but also has, for instance, a crossover deformity, subluxation, any of those of the second, I will at this point still be doing a open isolated shortening of the second. So I don't necessarily direct my percutaneous shortening osteotomies, my DMMOs, for isolated second MTP instability. Those are more for kind of diffuse metatarsalgia and stuff like that.
And you do
I'll leave it to
perc DMMOs?
Yes.
Okay. Pete, what's your preference?
So I prefer to try to, you know, lengthen the first ray a little bit, like Beccy said, plantar flex it just slightly. I personally stay away from isolated second metatarsal shortening osteotomies. I haven't done one in probably 10, 12 years. I have my own technique to repair the plantar plate on the plantar lateral aspect in a very kind of unique fashion. I think Jeff Johnson and Jeremy McCormick, I think, have described a little bit of Wash U, a similar sort of technique, and I have no problems with that issue. If I have a diffuse metatarsalgia, then I will do second, third, and fourth, but I'm not going to do an isolated second metatarsal shortening osteotomy. I'm not as much of a believer in the second toe is the problem. I think the first ray is the problem.
I agree with Pete that the first ray is the problem. I think if you can stay away from that second, it's just stay away from it because you're adding complication. And I think it's not causing the problem. I think you want to drop the head down or just lengthen the head out a bit if you can. And I think that's the key point is refunction the first ray, get that 50% weight bearing back into the medial column and avoid going to the second.
Kevin, any thoughts on the second ray?
No, I'm in alignment with Pete and what the other panelists have said, that, you know, for me, the second is just means you have an unstable MTP joint at the first, which is why most of them are coming to you. And you need to do a good job of restabilizing that. And if you do a good job of that, then you restore weight bearing through the sesamoids, and the big toe starts working again as a big toe. And then usually your second is going to be okay, other than, like we talked about, some of these rare and severe cases where 2, 3, 4 are all bad. But I think that isolated second's not a common problem for me.
And next question.
Alastair, there's another question that came in. Are all of you guys doing a lateral release? And if not, when do you decide to do lateral release? When do you decide to do lateral release, and at what point in your surgery do you decide to do the lateral release?
So, Becky, do you want to address that? That's a
Yeah.
specific issue on the Perk, actually. So
Yeah, and this is actually a really critical point about the minimally invasive or percutaneous chevron. Again, this is extracapsular. This is not intracapsular. So if you're going to do a lateral soft tissue release, unlike what you would do, for instance, with an open chevron, or specifically in my case, like an open scarf, you have to do it after you've done the translation of your, the metatarsal head of the osteotomy. If you do it before, you've lost a lot of the stability of being able to control the position of the head. So that's really important. Make sure if you're doing a lateral soft tissue release with this, it's only done after you have translated it and fixed it. And what I typically do is after I've finished my chevron, and I don't think it really matters whether you do it after the chevron and if you're doing the Aitkin, I look at the joint, and if the sesamoids still look laterally translated and or the joint still looks a little incongruent, those are the sort of deciding factors for me to go ahead and do the lateral soft tissue release. Again, I've already done my chevron, it's already fixed. And what I'll do with the beaver blade under the fluoro is I'll go in along the lateral side of the joint, lateral to my EHL, use fluoro for your guidance, and I get down to that lateral side of the joint with my beaver blade in line with the joint and the blade itself. You won't hurt the nerve that way. And I get down to that, attachment site of the FHB laterally, right at the base of the proximal phalanx. And I'll sit there and hold the toe and sort of kind of put it in some varus force. And I sit there and use the beaver blade and feel how it's a gritty type feel that you'll feel when you get to the FHB attachment there. And I'll release that off the base of that. And that's the times I do it. Again, it's critical to remember to do it after the fact. And then I don't do it often, but I do probably maybe 15, 20% of my cases. And that's the technique that I use.
Pete?
When I first started doing these, I did release the lateral capsule. I can probably say in the last year and a half, I have not released one lateral capsule. And I think that's because of what I've found is, again, if I translate the head over far enough laterally, I don't have the issue of continued residual tightness in the extracapsular osteotomy process. And in fact, that's part of what I think leads to arthritic development, in the old techniques of tightening up the capsule, and you're basically, creating some sort of unusual forces in the capsular soft tissue attachments, much like we, used to over tighten or under tighten a shoulder or a knee. You get arthritic changes, right? So that I want to leave the capsule and really try not to mess with the capsule and realign it by shifting the head over far enough to the lateral side.
And with your lapidus, Kevin, are you always releasing or occasionally?
Yeah, with the lapidus, I'm always releasing, but I think that it's one of those mysteries of orthopedics where it's not a completely solved thing. As Pete points out, that if the head is back over beside 2, how critical it is, I guess, clearly I've met enough good MICA surgeons who've done lots of cases and followed them up that with that technique you can do it and not have to do the release. The sesamoid reduction, and if to me, is partly driven by how much remodeling of the plantar metatarsal head do they have. that when you're examining them in the clinic, that if they have good functional extension, you know that the sesamoids will have good excursion, then maybe it becomes less important. In some of the older patients where they don't have a lot of extension, I think trying to get some mobilization of the lateral sesamoids important for stopping early recurrence, or just leaving them with functional hallux limitus.
Okay. We're getting short of time, but I'm just going to, we'll just move along here. This is just an illustrative case of where we've been more recently too with this, and a patient who has hallux valgus, and a case of mine where we did a percutaneous lapidus and an Aitkin, and just demonstrating some of the correction. Becky, your case there with the older patient, what have you found with them with osteoporosis? Are you staying away from the Mica, or what?
I don't have a good answer for that. So that woman was about 65, and it's funny, that same day I did her surgery, I had 3 Micas. 2 women before her were in their late 40s or early 50s. One woman had horrific bone density. And then the 65-year-old had skin like a 20-year-old. Her bone was, great. I mean, when you're putting those screws in, you have great density. So it's like, I don't think I have an age cutoff. Certainly, I don't routinely send my patients. I routinely send all my patients for a vitamin D, any bony type of procedure I do, irrespective of bunion. But it's not like I send my patients who are, certainly postmenopausal women for DEXA scans to choose to do. But I do feel like, Andy, I do the scarf, and there are situations I still do a scarf. And I think if I'm really worried about, if a patient comes in and she has known osteoporosis, she's older, her joint looks great, I don't want to necessarily do a fusion on it. I feel very confident and comfortable in the stability of a scarf, not relying on that hardware for its fixation. Whereas I think the Mica, you're relying on the strength of that bone to engage and hold those screws, at least certainly to get them weight bearing in the beginning.
To wrap this up, Alastair, thanks for moderating a great session. MIS is such an interesting area right now, and there's a focus of a small group of us who are doing a lot of it, but I think at least I see the fellows and residents really getting more and more interested in it. So thanks again, you guys, and we'll be back in a few moments.
Thanks,
Thank you.
Becky. That was awesome.
Thanks, everyone. Thank you.